The non-surgical bone graft, or perhaps scientifically, this could be referred to as a microsurgical bone graft. I chose the word non-surgical bone graft because I think that term is more appealing to the patient, sounds more conservative, and does not involve any sutures or incisions. Is this a hopeless tooth? Tooth number 8 has a 10 millimeter pocket on the mesial, 7 millimeter pocket mid-facial, and a circumferential pocket going around toward the mesial, and a 7 millimeter pocket on the mid-palatal. And most people would classify that as a class 3 mobility. Now let's score number 8 using the MMPPI score. Now you will remember in the original study that we only scored molars. And the reason for that was if I treated a single rooted tooth, I very seldom lost it. But you can apply the MMPPI to a single rooted tooth, and let's look at that. On that particular tooth, we score a 7. And you will notice that there is no score on molar type or frication, and this accounts for the reason that a single rooted tooth has such a great prognosis. And we can go ahead and score the tooth postoperatively and find that we can lower the score from a 7 to a 4. Remember, a 7 means it's got an 86% chance of surviving for 15 years, and a 4 a 95% for 15 years. I think these numbers should be shared with the patient before giving them the treatment option of extracting teeth. A technique. Obviously, you want to anesthetize the patient, and you want to sharpen both the tooth side and the soft tissue side of the curette. Basically, the curette that I use on this is 11 and 12. And you want to root plane in 3 planes: vertically, obliquely, and circumferentially, to be sure that you do remove the accretions on the root. Initially, I will probably root plane the first 4 or 5 millimeters vertically, and then as I go deeper, I will begin root planing obliquely. And then in the apical aspect, I may switch to a 13-14 curette and root plane circumferentially, trying to get as much granulation tissue out and creating a cul-de-sac. Now, remove as much of the granulation tissue as you can and create the cul-de-sac that I just mentioned for placing the bone graft material. Continuing, use the back side of the curette or a small amalgam plugger to pack bone as densely as possible. Seal with cyanoacrylate and be sure and adjust the occlusion, because many of these teeth are extruded and are in hyperocclusion, and once you tamp the bone material around there, the tooth is markedly stable and may interfere with occlusion. So you often need to adjust the opposing tooth and certainly the incisal edge, because the tooth will probably interfere in protrusive. On the left, you see the bone graft material that we're going to use. This is about 30% calcium sulfate, which not only is a regenerative material, but also adds adhesiveness to the bone graft particles. And we're using FDBA, freeze-dried bone allograft. You can see how this is heaped up because of the adhesive properties of the calcium sulfate. On the right, you can see where this has been densely packed, and we're now probing that to be sure that the cul-de-sac is well filled with bone. Now we're checking to see if the cul-de-sac has been well filled with bone. A word of caution: in packing this, seldom are you able to pack the bone all the way down to the crest of the bone. And typically, if you take an x-ray, there will be a radiolucent or dark area right incisal to the crest of the bone. Don't be concerned about that, for that area will fill in as the bone graft heals. And then we're taking the cyanoacrylate that we mentioned to seal and stabilize the wound. Not on this case, but later on, I would take and cut off a small wedge of a 2x2 sponge, place it in the diastema area, and let that set up and let that stay for as long as it will to keep food from packing into the area. And sometimes that will stay in place 4 to 6 weeks, and that's all right. So this is our pre-op view, and this is the view about 5 months later. And you will note that we have shortened the incisal edge, as you can see from the black line on the left. We have lost little tissue in the papilla area. We have an aesthetic result, although the diastema does persist. Do not probe this area for several months. And when the patient comes in for a 3 to 6 months recall, do not probe this area because the attachment is still maturing. At the end of a year, that 10 millimeter defect will probably probe about a 5. Seldom, if ever, do you get totally rid of the probing depth. Now let's talk about the impact of closing the diastema. And this is a different case, but let's see the argument for doing that with a non-surgical bone graft. Here's the pre-treatment view, and you notice the wide diastema that we have. And as we look at that, the patient has a full dentition, having some very nice gold work in the mandibular arch, so she has had quality dentistry. But if we look on the left, we can see how tooth number 8 is severely malposed. We look at the x-ray, and I apologize for this does not show very well, but look on the mesial of number 8, the severe bone loss we have there, and the yellow line at the top showing where the apex is, so we do have very significant bone loss. And on the right, the patient has lost the canine and a 3-unit bridge using the lateral as an abutment, you note, and you can note the circumferential bone loss around that tooth. And in the eyes of most dentists, both of those teeth would be hopeless. But the problem is that if you're going to do an implant treatment plan, in all probability, tooth number 9 is going to be sacrificed, and that is a perfectly good tooth. So here we see the post-op view after the bone grafting has been done, and you will notice the little fine line orthodontic treatment has been completed. So here we see the pre-op with the tooth extruded on the left and following orthodontic treatment on the right. Here we have a class 2 frenum, and to learn more about the frenum, go to the video treatment of the mandibular of the frenum. And you can see the fleshy frenum that has been created on the left when these teeth were brought together, and a very close-up view on the right. So the frenectomy is going to be done with a laterally positioned flap. This has been also called a pedicle flap or a sliding flap, but the proper nomenclature is a laterally positioned flap. And there's a video on here dealing with the nomenclature that should be appropriate for periodontoplastic surgery. And after the frenectomy is done, you will notice on the right where we're going to deepithelialize the papilla without reducing the height. And we will see how that is going to turn out. After you have prepared your laterally positioned flap, then you want to close the lip sutures as we're seeing here. And when you close the lip sutures, look on the left how that positions that laterally positioned flap. And on the right, we can see this is sutured with 5/0 gut sutures. The papilla height has been maintained, but what I want you to see is on the right where the edentulous area was left. This should be in an interdental area, not over a root prominence. On the left, we see the pre-op before the frenectomy. On the right, you see the post-frenectomy and the aesthetic result that occurred. So, perhaps some localized crown lengthening would be indicated, and on tooth number 9, the tissue that we see incisal to the yellow line should be excised. Actually, we went in and did that with a radiosurgery, but it bounded back. So if we had gotten the result that we wanted, we would have to have flapped and removed bone. And since the patient had been through so much, she elected not to have that done. So on the left, we see the pre-op view, and on the right, we see the post-op view with an MMPPI of a 4. The patient was extremely happy because we have not only saved a tooth, but we have had a markedly simplified treatment plan, and in all probability, a less expensive treatment plan. The impact of the non-surgical bone graft in these 2 cases has been very dramatic. But it lets you know that unless you score teeth using the MMPPI and find out exactly what the prognosis is and follow the protocol for the non-surgical bone graft, I think you're really missing the boat and unnecessarily extracting salvageable teeth.